Hello, dear viewers. Welcome to today's webinar organized by the EFIM Young Internists and Austrian Young Internists. My name is Jakub Jurica. I will be one of your moderators today. I work at the first department of internal medicine at Martin University Hospital, and today's session will focus on the clinical use and applications of GLP-1 receptor agonists. Before I introduce my co-moderator and colleague, I will also like to point out that the Q&A session will be held after the presentation and that the whole session is going to be recorded. So you can find the recording available on the YouTube channel of EFIM in a few weeks time. So without further ado from my side, I would like to introduce my co-moderator, Dr. Noor Lasheen, who is an internal medicine resident working at the Brothers of Mercy Hospital in Eisenstadt. Noor, over to you.
Hello. Thank you for joining us today for this presentation on GLP-1 receptor agonists applications in clinical practice. My name is Noor and I'm in training. I'm a resident in training for internal medicine at Brothers of Mercy Hospital. Today's presentation will be held by my colleague who is a specialist for internal medicine and endocrinology. Also working at Brothers of Mercy Hospital in Eisenstadt, Dr. Adrian Szodl. We're happy to have you, so please introduce yourself and we can start off the presentation, I think.
Thank you for your invitation. I will start my presentation. So, thank you for your invitation and the introduction. Today I will talk about GLP-1 receptor agonists and the applications in clinical practice. My name is Adrian Szodl. I also work like Noor in the Hospital of Mercy Brothers in Eisenstadt, and I'm a specialist for internal medicine and currently in additional training for endocrinology and diabetology, and then I'm a member of the Young Diabetologists of Austria. A short disclaimer for our audience because this is recorded and presented on YouTube. I have no conflicts of interest regarding this lecture. Today I will talk about incretin hormones, the incretin effects, then the pharmacological use in diabetes and weight loss, and also about cardiovascular and kidney safety profiles and benefits, adverse events and side effects that occur under the treatment, new fields for the use of GLP-1 receptor agonists, and the future of the incretin therapy. A bit of historic. 1906, there was an experiment conducted where intestinal mucosa extract showed that it affects glucosuria in patients with type 2 diabetes. 1929, the terminology incretin was first used, and 1945, there was an observation that there's a difference in glucose deposition after oral intake compared with IV administration of glucose. And 1964, there was shown that there's a higher insulin response after oral glucose intake compared with the same amount of IV administration. So what triggers this insulin secretion if it's not the serum glucose alone? And the answer is the incretin hormones. Incretin hormones are a family of hormones. The most two important I will present you today. First of all, there's the glucagon-like peptide 1, short GLP-1. It is produced by the intestinal L cells and is stimulated by contact with glucose and fat and degraded by dipeptidyl peptidase 4, and therefore has a short half-life of about 2 minutes in circulation. Another important incretin hormone is the glucose-dependent insulinotropic polypeptide, which is produced in the K cells of the duodenum and jejunum, and also stimulated by glucose and fat, and also degraded by DPP4. So if we look at the effects of GLP-1, it has an effect on the central nervous system as it decreases appetite but can induce nausea. In the cardiovascular system, we see a slight drop in blood pressure and a slight increase in heart rate. And for the stomach, it delays the gastric emptying and motility. And the effects on the pancreas are an increased insulin secretion, a better cell protection, and glucagon secretion gets decreased. That's some of the effects. There are many others, but it would exceed the limit of the lecture today. When we look at GLP-1 with a half-life of 2 minutes, it is not a good pharmacon to be used as a pharmacal treatment because it would have been administered continuously. And therefore, there was a discovery of exendin 4, which is produced and found in the saliva of the Gila monster. This is a kind of lizard found in the southern part of Northern America. And it showed a 50% sequence homology to natural GLP-1. And therefore has an increased half-life of few hours and therefore can be used in the pharmacological treatment. Here we see the amino acid sequence of GLP-1 and exendin 4 and one specific mutation on the second amino acid improves the half-life. And therefore we have the pharmacological development. Exenatide was the first treatment to be approved for the treatment of type 2 diabetes. It is the synthetic produced form of exendin 4, which I showed you before. It has to be injected twice daily because of the short half-life of a few hours. Afterwards, exendin 4 exenatide was adapted in capsule to increase half-life and therefore could be injected once weekly. And another derivative which is derived from exendin 4 is lixisenatide, which has to be injected once daily and was introduced in 2013. I showed you the pharmacons which are derived from exendin 4 from the saliva of the Gila monster, but there were also developments with the natural sequence of GLP-1. And therefore was the first one which is derived from the natural human form of GLP-1 was liraglutide, which was introduced 2009. And it is linked to a fatty acid, which increases the half-life and therefore has to be injected just once daily. Afterwards, there was the invention of albiglutide, which is linked to albumin, also injectable once weekly, but it was withdrawn from the market 2018. Then we have dulaglutide, which is linked to an Fc fragment of immune globulin G4, also injected once weekly, and semaglutide, which is linked to a free fatty acid, also injectable once weekly. The next step was the invention of an oral application form from semaglutide. We all learned that peptide hormones have nearly no bioavailability because they are degraded in the digestive system, but combined with an absorption enhancer, short form SNAC, allows semaglutide to be absorbed by the gastric mucosa. Therefore, the medication had to be taken daily on empty stomach 30 minutes before food intake and still has a very low bioavailability, about 1 to 2%, and high inter-individual differences in the bioavailability. The last step of the medication we currently have in use is a combination of a GLP-1 receptor agonist with a CHIP receptor agonist, which is called tirzepatide. It's a single molecule that could activate GLP-1 and CHIP and is linked to a free fatty acid to increase the half-life and therefore is also injected once weekly. If we look the effects of GLP-1, which I presented you before, and add here the effect of the GIP receptor agonist, we see that in the central nervous system, it also decreases appetite, but in contrast to GLP-1, it lowers the nausea a bit. In the heart, we see also a small increase of heart rate, and in pancreas, we see also an insulin secretion increase, but also an increase in glucagon secretion. And in contrast to GLP-1, which has no direct effects on the adipose tissue, GIP has the possibility to improve the glucose uptake in the adipose tissue, triglyceride storage if there is a high insulin level in the blood, and increases lipolysis within low level of insulin in the blood. When we look on type 2 diabetes, we see type 2 diabetes is a metabolic disorder with insulin resistant and also a beta cell dysfunction. And the major risk factors are a genetic predisposition on the one hand, and on the other hand, obesity and lifestyle factors like unhealthy diet and low physical activity. So how can GLP-1 have a positive effect on the patients with type 2 diabetes? By reducing the appetite, we have a caloric intake reduction. By slowing the gastric emptying, we increase the time where the food is stored in the stomach, and there is not such a high glucose peak afterwards, and therefore the insulin production can take up with the glucose intake in the blood. Also, there is the glucagon secretion decreased, and we have an all ameliorated insulin secretion from the beta cell of the pancreas, and we also see a beta cell protection and beta cell proliferation because beta cells often go in apoptosis in patients with type 2 diabetes, and therefore posing the component of decreased insulin secretion. And when we look at the body weight decreases, and therefore we have an indirect effect of insulin sensitivity, which increases. All currently available GLP-1 receptor agonists and GLP-1 GIP receptor agonists are approved for the treatment of type 2 diabetes. When we look what the ESD-ADA consensus 2022 tell us about GLP-1 receptor agonists, they show they have a high to very high efficacy. It's hard to give you a number where glycosylated hemoglobin is decreased, but it can be around 1 to 2% about. GLP-1 receptor agonists should be considered before treating patients with type 2 diabetes with insulin because of the positive effects that we see under GLP-1 receptor agonists in patients with type 2 diabetes. And GLP-1 receptor agonists and GLP-1 GIP receptor agonists can be combined with all sorts of oral antihyperglycemic drugs. One exception is DDP4 inhibitors should not be combined because of the effect on the proteolytic degradation of GLP-1 and GIP. And it can also be combined with all types of insulin therapy. It doesn't matter if it's just basal insulin or mealtime insulin. When we look at the advantages we see with GLP-1 receptor agonists, in type 2 diabetes, we see a strong HbA1c reduction, a weight reduction, which is a positive effect for the mostly overweight patients with type 2 diabetes, and we see a cardiovascular safety of these drugs, and also a MACE benefit for liraglutide, dulaglutide, and semaglutide. And we also see no hyperglycemic risks, except if it's combined with insulin or the insulinic tropic substances like sulfonylurea. then it can occur that you have a hyperglycemic risk. And therefore, sometimes within the start of GLP-1 receptor therapy, a reduction of insulin therapy may be necessary if the blood sugar levels tend to go to the hyperglycemic range. It's hard to tell you now when GLP-1 receptor agonists should be used in your clinical practice, because this is a lecture for Europe, and therefore are different things that have to come in considerations. You should follow the local current guidelines for GLP-1 and GLP-1 GIP receptor agonists. And also always a thing that has to be considered is which medication is covered by the national healthcare insurances. When can you prescribe the medication with GLP-1, and what are the costs for the patients? And therefore, it has to be looked at these factors as well. Especially recommended are GLP-1 and GIP receptor agonists if there's an established cardiovascular disease or the high risk for a cardiovascular disease in type 2 diabetes, and with chronic kidney disease, and patients with obesity or overweight. Which brings me to the next application form and indication for GLP-1 receptor agonists. We see an increasing proportion of population is overweight or obese, and weight loss is, we all know it from our experience, it's hard to achieve, and the maintenance of weight loss is even harder to achieve. We have for obesity metabolic surgery, which is highly effective, but also invasive and has long-term side effects. And therefore, there's a need for potent weight loss drugs that can be used in these patient groups. We have here in Europe EMA-approved GLP-1 receptor agonists, liraglutide up to 3 milligrams and semaglutide up to 2.4 milligrams. These doses are usually higher as that one you use in the treatment of type 2 diabetes. And also approved is the GLP-1 receptor agonist for weight loss, tirzepatide, up to 15 milligrams per week. The weight loss which is achieved by GLP-1 receptor agonists is highly variable between individuals. And we see different effectiveness based on the used drugs for weight loss, and we have a different range of weight loss depending on the studies. Therefore, there are many figures published how many % of body weight loss is achieved by one drug, but they are also depending on the study where they are conducted. And there's a general fact that weight loss is generally lower in patients with type 2 diabetes compared with obese patients who don't show type 2 diabetes. From the weight loss trials, here are some examples. The SCALE trial used liraglutide and showed 56 weeks later on patients with no diabetes a body weight reduction of 8%. The STEP 8 trial showed that semaglutide versus liraglutide, also in patients with no diabetes but obesity or overweight plus comorbidities, showed a decrease in body weight of 15.8% versus semaglutide 6.4 on liraglutide. And with tirzepatide, we see after 72 weeks in also patient without diabetes a 20.2% reduction in body weight and 30.7% with semaglutide. These are quite high figures, and there's not much gap anymore if we use highly modern therapies compared to weight loss surgery. We also see additional benefits of weight loss. There are studies which showed improvement of knee osteoarthritis within semaglutide once weekly, and improvement of obstructive sleep apnea syndrome. Therefore, tirzepatide is approved in America by the FDA in the indication of obstructive sleep apnea syndrome with obesity. In Europe, it's just in the indication of overweight. And we also see non-cirrhotic metabolic dysfunction associated steatohepatitis, short for MASH. And there is a quite recent development, as there's a positive opinion by the EMA about 3 weeks ago for semaglutide that it will be in further investigation for approval and will be maybe approved for the treatment of MASH. As we treat our patients for weight loss with GLP-1 receptor agonists, there's often the question, how long should these drugs can be used, and what happens if you stop them? And there is a nice paper that showed and answered exactly this question. And if we look at the data, then we see after GLP-1 or GLP-1 chip receptor agonists are stopped, there's an average monthly increase of 0.4 kilograms per month. And the metabolic markers, which improved under therapy, returned back to baseline by 1.4 years. And the rate return to baseline happens after stopping the treatment in 1.5 to 1.7 years. And there is a trend where we see that with the highly effective modern therapies, where patients decrease more in weight, tend to have a faster and higher increase in weight afterwards, and therefore reaching their baseline weight earlier. Another important fact is when we're talking about therapy for type 2 diabetes and overweight are cardiovascular effects. Cardiovascular outcome trials are necessary for the approval of an anti-hyperglycemic drug, and therefore has been shown that all available GLP-1 receptor agonists and GLP-1 chip receptor agonist is cardiovascular safe. But we see sometimes additional benefits for long-acting receptor agonists. And therefore, for liraglutide in the LEADER trial, semaglutide in the SUSTAIN-6 trial subcutaneously, not in the oral form as shown in PIONEER 6, and dulaglutide in the REWIND trial, we see that there is a significant reduction in MACE, which is an combined endpoint of cardiovascular death, non-fatal myocardial infarction, non-fatal stroke, compared to placebo. And also, there's a significant MACE reduction for semaglutide in an overweight trial without diabetes, but with established cardiovascular diseases. Therefore, what does the European Cardiac Society tell us about GLP-1 receptor agonists? If we look in the guidelines for chronic coronary syndromes, we see that they have a class 1A recommendation for GLP-1 receptor agonists in patients with chronic coronary syndrome and in patients without type 2 diabetes, but which are overweight. There's a class 2A/B indication for semaglutide. If we look at the cardiovascular effect of tirzepatide, because the outcome trials were published in late 2025, the current guidelines mostly do not increase the cardiovascular outcome trial of tirzepatide, but it showed a non-inferiority compared with dulaglutide and a MACE benefit compared to a putative placebo. Another important organ which often shows comorbidities in patients with type 2 diabetes and overweight is chronic kidney disease. And if we look at about the effects on GLP-1 receptor agonists for the kidney endpoints, we see that we have a benefit in liraglutide, dulaglutide, and semaglutide in the subcutaneously form. The FLOW trial was a kidney endpoint trial with semaglutide 1 milligram, which showed a slower decline in eGFR and less achievement of the primary kidney endpoint. In the overweight trials, we see that semaglutide SELECT trial also has the ability to reduce the 5-point kidney endpoint in patients without diabetes but established cardiovascular disease. And a special trial with tirzepatide showed in heart failure patients with preserved ejection fraction obesity even a slightly increase in eGFR after 52 weeks of treatment and reduction in urinary albumin creatinine ratio. Therefore, the KDIGO guidelines, the International Kidney Guidelines for chronic kidney disease, recommend long-acting GLP-1 receptor agonists to achieve glycemic targets, if not achieved with metformin and SGLT2 inhibitors alone. Maybe in the future, GLP-1 will also rank higher in the therapy with diabetes within kidney diseases. And as chronic kidney disease and kidney failure is often present in patients with type 2 diabetes, we have to adapt our therapy to the according kidney function, and therefore GLP-1 receptor agonists are a very good chance for treatment because there is no dose adjustment needed and can be used to quite very low eGFR data. Just for the exenatide therapies, we have higher ranges, but the modern long-lasting GLP-1 receptor agonists can be used till the terminal kidney failure. And also we see, even if there's limited data for severe kidney disease, also patients on dialysis also have positive effects on glycemic control within GLP-1 receptor agonists. If you look at the combined GLP-1 GIP receptor agonists, we see the same recommendation according to product information that there's no dose adjustment needed in kidney failure, but limited data for chronic severe kidney disease. The professor from whom I learned pharmacology always said pharmacon which don't has side effects maybe don't have effects at all, and so is it also with GLP-1 receptor agonists. The adverse events and side effects are mostly of gastrointestinal nature, which includes nausea, vomiting, and diarrhea. If you have patients that show these problems, it has to be, the clinician has to be aware that can occur a lot of fluid loss, which can lead to kidney failure. Other patients describe obstipation, quite the opposite of diarrhea, and dyspepsia, reflux, and abdominal discomfort produced by the delay in gastric emptying. We also see a slight increase in cholelithiasis and gallbladder diseases. And for the anesthesiologists, an interesting topic is that aspiration can occur during intubation on patients with GLP-1 receptor agonists because the fasting periods may be too short to completely empty in the stomach within use of GLP-1 receptor agonists. And if we look at lab studies, we see in many patients treated with GLP-1 receptor agonists that they show an increased lipase and amylase levels in lab studies which have no pathological value. When we look at another organ which can be affected by GLP-1 receptor agonists is the eye. Especially it can occur that a diabetic retinopathy can worsen at the start of the treatment, especially if the patient is treated with insulin and GLP-1 receptor in combination and there's a poor metabolic control, because the a sharp decline in glucose may affect the worsening of diabetic retinopathy and therefore should used with caution, especially at the beginning. Afterwards, in the long-term effects, it has protective effects for diabetic retinopathy. And a very rare, very severe side effect is the non-arteritic anterior ischemic optic neuropathy, short from NAON, which can lead to an irreversible damage to the optic nerve. Other adverse events, when we talk about GLP-1 receptor agonists, often there comes the studies with medullary thyroid cancer, a special subtype of thyroid cancer, where we see that GLP-1 receptor agonists have negative effects on this kind of cancer in rodent models, but the human data is conflicting about the effect in humans. Some bigger studies and meta-analysis show no association. Some show a quite weak association, but the effect size is quite small. And therefore, the FDA in the American products has a box warning where it should not be used in patients with or family history of medullary thyroid carcinoma or people with MEN2 syndrome. In Europe, the EMA product information just states the relevance for humans is considered to be low, but cannot be completely excluded. But the effect size is quite small and it's actual under further investigation. When we talk about GLP-1 receptor agonists, often acute pancreatitis is mentioned, but there's also conflicting evidence of acute pancreatitis as side effect of GLP-1 receptor agonists, and the recent data show no increase in pancreatitis. There are even data that showed that if a pancreatitis occurs under GLP-1 receptor agonists, it may be less severe. But we have one study that showed that in patients with history of pancreatitis, they may be at risk for another kind of occurrence of pancreatitis. And therefore, according to the product information, it should be used with caution in patients with history of pancreatitis. But in general, it's not a common side effect. And as I said before, further studies will show us if it's a side effect at all. And one important fact regarding to acute pancreatitis, the asymptomatic increased serum amylase or lipase, which I stated before, is not a pancreatitis. Pancreatitis is defined as threefold upper level of norm plus pain plus imaging changes, and two of the three criteria has to be fulfilled to diagnose acute pancreatitis, and just an increased lipase on a routine lab study does not indicate pancreatitis or the risk for pancreatitis. So if we use GLP-1 receptor agonists, it's important to inform the patient and talk about some points. First of all, most of the GLP-1 receptor agonists are to inject subcutaneously, and therefore the education how to inject and how to use the injector is very important for the patient. There are different systems. There are multi-use systems, there are single-use systems where you have to apply the needle yourself, where you can give just one fixed dose or different doses to adopt with the GLP-1 receptor agonist pen. You have to inform the patient about effects and side effects. If you don't tell the patient with type 2 diabetes that they will lose weight with the therapy, they can be worried if they start to lose weight and the food doesn't taste as they were used to. And also the side effects, patient have to be informed that there can be nausea, there can be diarrhea, mostly at the beginning, and mostly the effects of nausea will decrease after 1 or 2 applications, and therefore should not be discontinued too fast. Dose escalation, that means starting with a lower dose and increasing the dose slowly, helps to reduce side effects. And if there are occurring side effects at a higher dose, a dose reduction may be necessary. GLP-1 receptor agonists in type 2 diabetes and for weight loss should always be combined with a healthy diet and exercise to prevent muscle loss. It's important to exercise and to look that there is no protein malnutrition. And sometimes it's important to tell the patient change of eating psychology, that they have to stop if they are full. Many persons have learned as small children that they have to finish the plate before they can stand up from the table, and always feel obliged to eat all the food that is on the table, and that should not be done, because otherwise, if the patient eat much above the feeling of satiety, nausea and vomiting can occur. Smaller portions are recommended, and the choice of food is also very important, because if there are smaller portions that can be eaten, it should be something healthy. If we look in the future for GLP-1 receptor agonists, which are currently under use, we see that some currently used GLP-1 receptor agonists may have neuroprotective ability. Retrospective data showed that it may have benefits in neurodegenerative diseases like Parkinson's and dementia. Also, according to mental health, there may be a positive effect on substance abuse like alcoholism. Other fields are the polycystic ovarian syndrome, where insulin resistance is a key pathological point in this disease. And when we talk about type 1 diabetes, and especially double diabetes, where persons with type 1 diabetes show the phenotype additional of a type 2 diabetes with overweight and insulin resistance, and increasing insulin dose by quite low metabolic control. We can talk about double diabetes, and currently the use of GLP-1 GIP receptor agonists are not approved for type 1 diabetes, but these patients may also profit from a GLP-1 receptor therapy, but prospective studies in this field are still missing, but under investigation. When we talk about the future of incretin therapy, a next development step is oral GLP-1 receptor agonists that are small molecule based and not peptide hormones like the oral semaglutide, and therefore have a higher bioavailability. It's one example there is orforglipron. And then there are new incretin hormone-based therapies like egnoglutide, which is a biased GLP-1 receptor agonist, and many combinations of dual and triple agonists like glucagon GLP-1 receptor combinations, then amylin GLP-1 receptor agonist combination, triple receptor combinations like with GIP, GLP-1 and glucagon co-agonists, and GLP-1 receptor agonists with GIP receptor antagonists, which also showed benefits in weight loss, which is a bit of confusing, because GIP agonism decreases weight, but GIP antagonism also decreases weight. And then there are amylin GLP-1 receptor co-agonists, which are under development for subcutaneously and oral administration. This leads me to my take-home messages. GLP-1 receptor agonists and GLP-1 CHIP receptor agonists are potent and effective drugs for the treatment of diabetes and obesity. The most of them are subcutaneously applied once per day or once per week, and for oral semaglutide, which has taken daily oral. Nausea and vomiting are the most common side effects. It's also important to look on diabetic retinopathy, especially within insulin therapy or poor metabolic control at beginning. Patient education is very important for this medication, and weight loss reverses 1.5 to 1.7 years after discontinuation. We see benefits for the cardiovascular diseases within GLP-1 receptor agonists, but also for chronic kidney diseases. And the current therapies are under investigation for new indications, and new drugs with new incretin hormone pathways are on the way. And therefore, thank you for your attention. And I think now it's time for questions.
So if there are, at the moment, we don't have any questions from the audience, so I will use my chance. Dr. Szodl, first of all, thank you for the excellent presentation and very, very enriching information about the use of GLP-1 receptor agonists for me personally, but I'm quite sure that for all of our young internists and also experienced internists in the audience. I would like to ask maybe one thing regarding the treatment of or combined treatment of a patient with heart failure and type 2 diabetes. If you were to choose a specific GLP-1 receptor agonist for a patient like that, let's say that the patient has heart failure with preserved ejection fraction, as we often see in diabetic patients with obesity and arterial hypertension, which one would you go for? Maybe based on the current information, or what's your clinical practice? Thank you very much.
We have data for obese patients with heart failure for semaglutide, 2.4 milligrams subcutaneously in the weight loss dose for patients without type 2 diabetes, and there was a positive effect shown in this patient group. And also, it's important to reduce the weight for patients with heart failure, which also improves the heart output.
Thank you.
I had a question in patients with type 2 diabetes and obesity, for example, or like if they are high risk, can we initiate GLP-1 agonists before metformin therapy, or should we always start with metformin?
It depends on the guidelines. Most of the diabetes guidelines start with metformin, but from a medical perspective, in patients with obesity, there is no contraindication to start with GLP-1 receptor agonists. But the problem is GLP-1 receptor agonists are quite expensive in comparison to the other anti-hyperglycemic drugs we have, and therefore the insurance may be the problem, which is covered by the insurance in the first line therapy. Yeah, that's the problem. But if it's covered by the insurance, it's medically possible and beneficial.
And you mentioned that the weight returns back to baseline in about 2 years. So is a lifelong therapy necessary? I mean,
It's quite interesting when you treat patients with type 2 diabetes and you prescribe something that has to be taken orally. Patient take it, and if you prescribe something that has to be applied subcutaneously, they always ask, "And how long do I have to take this?" And I say, as long as you live for most of the time, because with the other medications, you also take it lifelong, but many patients think it's like a short-term treatment, and after 3 months they are cured of the disease, and therefore patient education is very important. When we look at the weight loss data, it's quite sad when we see that the effect gets lost about 1.5 years afterwards, after you stop the therapy. But if you don't change the eating habits, physical activity, I think it's no surprise that the weight returns to the baseline.
We have a question from Javiera
Mhm.
in the chat. After reaching the target weight, can the doses be reduced without worrying about weight gain?
Yeah. That's an interesting question. You can try. Some patients will say a lower dose is sufficient to sustain the weight. Other patients will experience that the appetite increases, and we also see the effect after long-term use, that the effect decreases over time. It's the same with weight loss surgery. After a few years, the weight starts to regain afterwards, and the same effect is seen in GLP-1 receptor agonists, that about 2 years after therapy, the weight starts to increase slowly over the time.
I would maybe like to ask another question, a little bit going away from the clinical practice, and maybe Dr. Szodl, if you can give us an insight into what do you think might be other mechanisms at play that would explain the beneficial effect of GLP-1 receptor agonists on chronic kidney disease, on heart failure, on other obesity-related diseases that you mentioned in your PowerPoint presentation.
Yeah.
Those mechanisms beyond glycemic control. Thank you.
I showed you some mechanisms which GLP-1 receptor agonists have on different organs, but it's a quite complex system. It's quite oversimplified, as I showed you. There are cross-links between hormones and cross-links and indirect effects, which are part of because of the better glycemic control and about the better weight control, which have their effects on their own. But GLP-1 receptor agonists also have a variety of effects on different organs. Like there is an effect on the immune system. It decreases inflammatory markers. It can shown that decrease fibrosis, and therefore quite complex mechanisms, and many mechanisms which play hand in hand, I think show the effect of improvement for heart disease, for cardiovascular disease, and even for kidney disease. And if we add CHIP to this equation, we see even further reduction and other effects, which has to be taken in mind. Yeah.
And how do you select between GLP-1 agonists and SGLT2 inhibitors in patients with type 2 diabetes and heart failure? How do we select?
The guidelines tell us that patients with heart failure or kidney failure SGLT2 inhibitors are a crucial part of the therapy, because even in patients without type 2 diabetes, SGLT2 inhibitors are used for chronic kidney disease and chronic heart failure. But a good combination with SGLT2 inhibitors are GLP-1 receptor agonists, and they can be used in parallel. If you have a patient with type 2 diabetes which has heart failure and is obese, and your local insurance covers the therapy, I would say start with a GLP-1 receptor agonist, or add a GLP-1 receptor agonist for the management of diabetes and overweight. And for the heart and failure or kidney failure, I would prescribe an SGLT2 inhibitor in this indication, and therefore have all of the medication, because the effects add on, and the better the glycemic control, the better the long-term outcome. And with GLP-1 receptor agonists, we target two main pathophysiological problems: the overweight, and with the SGLT2 inhibitor, the mechanisms of heart and kidney failure.
Thank you. I don't know if we have any more questions.
I would try the last one if we don't have any other questions from the audience. Dr. Szodl, we've talked a lot about the mechanisms and beneficial effects of these drugs. We also have to look at, obviously, the side effects, as you stated at the beginning. I like that statement from your teacher from pharmacology. If you can give us maybe or offer some advice to those young internists, including myself, who manage certain patients at our hospitals or maybe offices with obesity. When we put them on this medication, they will come back in a few weeks time, complaining maybe about nausea, slight vomiting, or constipation, diarrhea. What sort of suggestions do you give to these patients, and how do you approach those escalation or maybe de-escalation in this case? Thank you.
I have 3 points to that question. First of all, dose escalation. If the patient tells me the low dose was no problem or slightly problem, and after 2 weeks they felt fine, the second dose was no problem, but the first dose escalation made problems, then I would switch the step 1 back, and would use the last dose that was tolerated fine, and maybe use 1 month, 2 months, 3 months, and afterwards try to increase the dose again. And if it fails again, then stay with the lower dose, because the lower dose is more efficient than no dose.
Okay.
On the other hand, if the problems, the side effects with nausea occur quite at the beginning, you can try a symptomatic treatment with anti-vomiting, anti-nausea agents, like in the all other patients with gastroenteritis, and look if the side effects will decrease. Some patients will start with nausea and don't decrease in nausea. There's a small proportion of patients, but then we have, if they don't tolerate the lowest dose, to discontinue this kind of therapy. Sometimes I would try to use another GLP-1 receptor agonist or a GLP-1 CHIP co-receptor agonist, because CHIP has the effect to lower nausea a bit, and therefore maybe in this patient population have a higher tolerance in side effects. And also educate the patients that they should use smaller portions, eat healthier food, and try not to overeat, because overeating often causes the problems of vomiting and nausea, because of the stomach is full, and the gastroparesis, which is induced with GLP-1 receptor agonists.
Okay, thank you for the sufficient answer, Dr. Szodl. And With this last answer, I think we can conclude the Q&A section. I would like to remind everybody again that this session has been and is still being recorded, and it will be available on the EFIM YouTube channel in a few weeks' time. And also, from my side, one last suggestion, or maybe um, a message of what's to come. The EFIM Young Internists, together with the young nephrologists, will be organizing a webinar on the topic of amyloidosis. The date is not set, but that will be the topic of the next webinar, so stay tuned. And I would like to pass it over again to Dr. Lasheen for the final remarks. Thank you.
Yeah, thank you very much, Dr. Szodl, for this nice presentation. It was really interesting, and I think there were no questions because everything was already discussed. So I would just like to mention in March, 25th to the 28th of March, there will be a European Congress of Internal Medicine in Vienna. And there will be a lot of interesting events for young internists. So it's I would invite everybody to join. Thank you very much, Dr. Jurica and Dr. Lazarova, for this nice presentation, for joining and for moderating. And thank you again, Dr. Szodl. It was very interesting. And yeah, with that being said,
Yeah,
Thank you
thank you
for the
very much.
invitation.
thank you to Dr. Szodl.
Thank you.